Hello, Dr. Russ here. Today we have Jeneen, and we're going to be looking at Jeneen's right leg for a neurological exam, and then we're going to be doing some traction and then an adjustment for her upper body as well. A couple of years ago, Jeneen had a disc herniation, which was quite severe and required surgery. I supported that decision to go for surgery. It helped a lot, but she's still left with some consistent and persistent numbness and tingling in the right leg. So we want to see exactly what's going on there and if we can track it down. Part of me says it's still healing from the herniation and the surgery, but let's see if we can quantify that. Anything you want to add to that?
No, that's it.
Good. Is there pain that goes down the leg, or is it just numbness and tingling?
Only in the morning when I stretch, and then it gets a Charlie horse.
Okay.
But not consistent pain.
Charlie horse in the calf, in the foot?
Calf, and then sometimes in my thigh.
The hamstring?
Hamstring,
the back
yeah.
of the thigh?
Mm-hmm.
Okay. If you take a deep breath in and hold your breath and bear down like you're trying to push out a baby, does that increase your pain? Mm-hmm. There's no sense of increased pain there. Okay. Will you lay on your back? Mm-hmm. Well, let's just start with a simple straight leg raise and see if there's nerve root tension when she's just laying in a non-weight bearing position. So I just want you to let me lift up your leg. And when we do this test, the straight leg raise, we want the hip to be neutral or even slightly internally rotated, because if it's externally rotated, that's putting more slack in the sciatic nerve, and we want to put some tension through that nerve and see. So I just want to know if this creates pain in the back of the hip, increased numbness or tingling in the foot, if anything starts to cramp or spasm, or is it just like a stretch in the hamstring, a stretch in the calf?
Yeah, just a stretch.
Just a stretch, okay. So we're going to increase this a little bit. We're going to increase the tension on the nerve without increasing the flexion of the hip by just sort of gently pulling up on the toes. And this is Braggard's test. And how does that feel right there? Calf stretch or something more?
Just calf.
Just calf stretch, good. So that feels all right. Let's look closely at the toes here, and we're going to do some muscle testing. So I'm going to start with you by pulling your toes up toward your forehead. Okay. Yep, both sides. I want you to hold them there, okay? I'm going to pull on the big toe on the right. This is the affected side. That's really strong. And on this side, really, really strong. Can you curl your toes now? Good. So if this cramps, just let go, but I'm going to push on the big toes on both sides. Good. Nice and strong. And now the little toes. Good. So all 10 toes, flexion and extension, are perfectly strong, plus 5 out of 5. On the right foot, you're going to bring it into this position. So you can see her tibialis anterior pop up there. That's the muscle we're testing. This is the L4 nerve root. So I push. She's very, very strong. Good. You're going to bring it up and out. Mm-hmm. Push here. Nice. Bring it down now. Mm-hmm. And turn it in. This is for tibialis posterior, L5. And down, put down, and out. And that's S1. And that's really strong all around. Since the right side is the affected side, we're not going to bother to test the left side. Let's test some sensation, okay? We're going to start by testing your vibration sensation that will be lost first if there's compression on the nerve. So I want to know, first on your left side, do you feel, you feel that? Mm-hmm. Okay.
Yes.
What does it feel like?
Like vibration.
Okay. And tell me when it stops.
Stop.
Good. So let's try that on the right side.
Yeah, I feel it.
You feel it. Good. Tell me when it stops.
Stop.
Good. And one more time. So we did medial foot. We're going to do lateral foot. Do you feel that?
Not the vibration.
Nope.
Just the pressure.
So it's vibrating pretty good. She doesn't feel it on the lateral foot.
No.
Nope. Okay. So I'm going to stop it. Did that change the sensation at all?
No.
Okay. So there's loss of vibration sense on the lateral foot. So here we do pinprick. So this is the wheel. It's not like a pizza cutter. We don't want to press. It's really just the weight of the pinwheel that we're looking for. And the way I like to do this is to demonstrate on the unaffected side. Okay. Prickly. And dull. Those feel different?
Yeah.
Prickly?
Yeah.
Dull. Okay, and when I'm doing dull, it's just the blunt side. So here on the lateral calf, prickly or dull?
It's prickly.
Prickly, okay. Medial calf?
Yeah.
Prickly?
Uh-huh.
Okay. How about here? Prickly or dull?
Dull.
Good. How about here?
Dull.
Good. And now?
Prickly.
So she can definitely sense prickly to dull. Does that stay prickly? Oh, yep.
Yeah.
So that withdrawal, that's part of the normal response. So I'm just going to go straight across the top of your foot, prickly or dull?
Prickly.
All the way across.
Prickly.
Okay. So I'm noticing a scar here. Was that a bunion surgery?
Yeah. I was young.
Okay. Let's check the sole of the foot here, prickly or dull.
Dull.
Okay. So that was prickly. Let's try that again. Okay.
It's not prickly as much like it was.
Okay. Let's compare that to the left foot, okay? Here's the sole of the left foot.
It's a little pricklier.
And here's the sole of the right foot.
Yeah.
Okay. On the outside, so the lateral foot, is that prickly or dull?
Dull.
Okay. And is that prickly or dull?
A little bit of prickly on the top.
A little prickly. Okay. So there's a distinct loss of sensation. It seems to be confined to the lateral foot. And that's where we're at. So this is more of the S1 dermatome. But those things are very variable from person to person. She didn't read the textbook. She doesn't know exactly where. So we know it's lower lumbar for sure. It's on the right side. And there does seem to be some slight compression of the nerve. So the nerve itself is like a cable. And the outer layers of the cable, the outer fibers on the cable, generally innervate the skin, and the inner fibers generally innervate the muscle. So when there is a slight compression, you're going to get these skin sensations, and because your muscle function is totally intact, that means that whatever compression is on the nerve is light. It's not severe, but that's where we're at. So thank you. Let's have you turn over. So we have Jeneen prone. You can see the scar. Was it a microdiscectomy?
Yes.
Do you know? It was. So not a laminectomy,
No.
not a fusion.
No.
There's no hardware in there, which is good for us to know as body workers because if there is, that titanium or steel cannot be changed. So it changes the way that we approach it and what our goals would be and what we think her response would be. So just to orient myself, this is her right side. Kind of always need to remind myself right from left when the patient turns over. And this is the affected sciatic side, but we also want to remember that her body is three-dimensional and the disc is three-dimensional. And just because it happened to herniate to the right doesn't mean it wasn't also problematic in its whole three-dimensional extent. And just my first impression here as I'm working and touching just basically at skin level is some definite resistance to P to A pressure on the right side of her sacrum and the right side of her pelvis. So I'm just making note of that. Maybe we can change that in this session today and maybe not, but it's definitely there. And it definitely correlates to what we're seeing with a little bit of nerve root compression on the right side. So generally speaking, the smaller the area of symptom, neurological symptom, the more that area corresponds to a dermatomal pattern, the more likely it is that the entrapment is close into the spine. It's more proximal. It's not 100%, but if, sometimes people who have had disc stuff in the past, they'll have entrapment of the peroneal nerve behind the fibula. And it'll look and feel a lot like a radicular problem, but it's a peripheral problem. The difference there would be in the distribution of the symptom. It wouldn't be necessarily in such a dermatomally consistent pattern. So we're working on the assumption that this is still a radicular problem. The question about her Charlie horses in the morning, I think that's probably best explained by the fact that anything that's a little swollen during the day is going to be more swollen at night and most swollen when you first wake up in the morning. Partially because you're not moving when you sleep, so things do tend to stagnate and congeal. And partially because your cortisol is lowest between 2 and 4 a.m. Cortisol being our body's main anti-inflammatory hormone. So when that cortisol is lowest, our inflammation and swelling tends to be highest. And that's not in and of itself problematic. That's one of the reasons why our body heals when we sleep. But that does mean sometimes we wake up feeling a little bit stiff. So what I've been doing here is a gentle stretch on her gluteal fascia. So moving from the sacral fascia over into the gluteal fascia, my pressure is very moderate. It's not heavy at all. I'm not going for trigger points. I'm not digging on the piriformis or those deep lateral rotators. We'll probably do that. We might do that in this session, or we might do that in the next one. Because I looked at your file today, Jeneen. I haven't seen you in almost a year. Mm-hmm. So it's been a while, and we don't want to try to do a whole year's worth of work in one session. Mm-hmm. Nice deep breath for me. Good. And let it all the way out. So I'm just kind of giving her right side the first taste of a little traction, because we're going to use the traction table. And again, we like to approach things incrementally and gently and not surprise the tissues, because usually they don't respond too well to that. Nice deep breath. Yeah, it's perfect. Really nice. Good. Okay, let's shift over to the left side for a bit. Well, I can feel that what we did on her right side did help with that resistance to P to A pressure on the right. So that's nice. And we're going to kind of do more or less the same thing here on the left. Working the continuity from the sacral fascia to the gluteal fascia. And you can see I'm working proximal to distal here, which some might say is like, against the lymphatic flow. But the pressure is so gentle that it's not really that important right now. Nice deep breath. Good. And a little gentle traction. Really nice. One more time. Good. Good. Nice deep breath. Good. Okay. So my main areas of focus today with the traction mobilization is going to be both of her SI joints and the two lower lumbar segments. So let's do a little of that. Here we go. Nice deep breath in and let it on out. Good. So palpating as we use the foot pedal to create distraction on the table. Just want to feel the first bit of tension, like you're tuning a guitar string, and you just first start to feel that little bit of resistance. Good. So it's good deep breathing. And I'm using some gentle digital pressure to open these lateral borders of the sacrum. Really nice. Good. So far it's just been traction, no mobilization. A couple more deep breaths. Good. I know there's a lot of people out there who have had surgery or considered surgery on their lower back, and if you're wondering how can this be treated safely, because the last thing we would ever want to do would be to aggravate this condition and set a person back. So gently, incrementally, mindfully, nice deep breath. Good. 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 So right now, as you can see, I'm using this kind of a grip on her sacrum and moving the pelvis as a whole underneath the fifth lumbar. Starting to get a little mobility between L5 and the sacrum. And now we're going to move that up. And I've got my pointer on L4. A little bit of pressure to offer it some stability. So I can use the table to circumduct L5 underneath it. And you can see my movements is just a few degrees. So the amount of movement between each lumbar segment is maybe 5 or 7 degrees. It's not much. So we don't want to bottom the table out in flexion. We don't need to create full traction. It's really just a little bit. That's all we need. Nice deep breaths here. Good. How's that feel, Jeneen?
Really good.
Feels good?
Mm-hmm.
Okay, let's focus now on this left SI. So I got my thumb here. It would be cool if you had x-ray vision. You could see the lateral border of her sacrum here and the lower part of the SI joint right there, the upper SI joint right there. So if I could get my thumb hooked under the sacrum right here and use the table to start to rock her whole lower body while stabilizing her sacrum, that I can get just a couple of degrees or a couple millimeters of movement through that left SI. And you can see that I'm bringing her feet over to the right as I do this. That opens that left SI just a little bit, especially the superior or the upper joint. And so this is how we can get just a little bit of movement through the sacroiliac joint. And then once we sort of loosen it up a little bit, like loosening the lid of a peanut butter jar, then we can get a little bit more mobility through it. So here now I've released the pressure and the stabilization on the sacrum, and I'm just using a little pressure on that fascia, the superficial and deep fascia, to create some differential movement between the bone and between the fascia overlying it. So I'm kind of working my hand against the table. As I bring her feet to her left, I'm pushing a little bit to the right. I'm not trying to push the bone, I'm just trying to move that fascia. So we get that nice differential movement between the layers, which allows for better circulation, decongestion, work out some of that stagnation. And it's neurologically soothing as well, and nourishing. So I'm going to do the same thing now to her right side. I didn't pick the left side for any particular clinical reason. I was just standing there. So again, I'm going to hook on her sacrum. I'm going to work her feet over to her left. And from here, I'm going to stabilize her sacrum while I rock that right ilium into side bending and flexion. Get a little bit of opening through the SI joint. This side is certainly a little more resistant than the other. And my general principle, if I meet resistance in the body, is not immediately to try to push through it. Just engage it. Just engage it. And maybe gently, incrementally offer a slight incentive or a slight induction to move through. But meeting resistance in the body with force, especially if it's not really precise, it's just going to tire you out. Okay, so now working the fascia, overlying the sacrum, overlying the ilium, creating that differential movement. And in my mind, when I do this, I like to visualize the layers. The skin, superficial fascia, deep fascia, muscle, bone. Just to appreciate that it's there, and maybe even be receptive enough with my palpation to sense those different densities and textures and qualities of the tissue. Good. So we've got that. Now we're just going to do a couple of rounds of straight segmental flexion-distraction. Very conventional. Deep breaths coming up the lumbar spine. I am not pressing very much P to A. It's mostly traction up toward her head because I don't like to do straight P to A pressure on the lumbar spine. That doesn't feel good. Okay, so that is a session of segmental traction and mobilization for a post-surgical lower lumbar disc with some residual, mild, but definitely significant right-sided neurological phenomenon. So having done that, we're going to move up to the upper body. Jeneen, you don't need to move. Okay? But we're going to work this section here now, okay? Nice. So, as always, skin level is where we start. Let the area get accustomed to the touch, the sensation, and being worked. You don't want to go straight into the deep tissue. That's not compatible with patient relaxation. It's coming out a little more laterally, always wanting to move that intercostal fascia, always wanting to make sure the rib cage is not really stuck. So when the rib cage is stuck, it inhibits the breathing, and when the breathing is inhibited, it's really hard for the body to be feeling good. Nice deep breath. Good. This actually all feels really smooth. You've been working out?
Yeah,
Yep, good. Yep, your muscles feel really nicely developed. Skin's really healthy. The fascia feels really good. I'm actually really not feeling much to work on here at all, which is really nice. A little bit of tightness through this middle and lower thoracic spine. That's about it. So let's work with that. Okay, so I'm gonna take my fingertips, I'm gonna roll off of her spinous processes on the right side and create a little stretch of her erector spinae. It's very slight, just by tractioning them laterally. Thinking about getting a little space here between the spinous process and the erector spinae group. Just sliding it. Good. Coming up against a little taut muscle band right here. You tender here, Jeneen?
No.
Nope. So it's just a textural difference. It's not dysfunctional. And from the same side here, I can do the same thing to her left. Spinous processes are here. We're going to slide off and pull. Slide off and pull. Good. Nice, nice, nice. Good. Good. Okay, so we've got like a T9 right here. This is her 9th thoracic vertebra. And I'm getting the sense that it is rotated this way. So spinous left, that means body right. And she's a little posterior on the transverse process here. So we want to try to induce a little bit of leftward rotation in that vertebra. So her skin is pretty slippery from the oil and the shea butter, and that's okay. So my pressure is coming through my pisiform bone. It's fleshy, it's not super hard. I'm not extending my wrist to accentuate it. I'm keeping my wrist pretty neutral, so she's getting more of the flesh of my hypothenar as I just induce a little bit of left to right movement on that spinous process. And it's just a little bit of a scoop, just like that. Nice deep breath. And let it out. And because she's nice and relaxed and we've got everything underneath it pretty well mobilized, it's really easy to adjust it that way. It doesn't need any force. And right here, little posteriority of this rib, I'd call that rib 5, maybe 6. Nice deep breath here. So I'm going to give it a little P to A pressure. Again, the fleshy part of my hand. There's no need to accentuate your pisiform bone. That's just going to create pain. And they're going to tense up against that pain. Nice deep breath. Good job. And let that out. Good. And a tiny little thrust right there at the end. Easy. So we can do muscle work, myofascial work, assess for the need for segmental adjustments at the same time. And just integrate that adjustment right into the treatment. Just like that. Good. So another little rib issue right there. Good. Without moving, I'm just going to do this one from the same side. This one I'm going to go P to A with a little superior lift. And let's get my towel there for a little more traction. Nice deep breath. And let it all the way out. Good. 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 Okay. How do you feel about a neck adjustment today? You feel good? All right, so let's take our time and get you turned over. Again, a little oil on my hands. I'm going to pick up where I left off, which was around T1, 2. And just keep moving up the spine. This gentle traction, no tugging. And just kind of get a sense of how her tissues respond to being asked to lengthen a little bit. So just this gentle downward pressure on the shoulder to lengthen the upper trapezius and the levator scapula. And again, I'm really happy with the way this feels. I think you've been really taking good care of yourself. So good for you. Yeah. The initial couple of tractions, I felt some resistance on the right side, but that is pretty much dissolved as I gave her upper trap and levator just a little bit of elongation. So that was more what I think of as surface tension, just what people are carrying around, rather than some deep dysfunction that needs to be addressed. So I've got my left thumb on the front part of the transverse process of her cervical spine here, and I'm assessing her rotational segmental mobility by turning her to that same side and giving very slight A to P pressure on those transverse processes. This is just one way for us to assess cervical segmental mobility. Here's what it looks like on the right side. You can see I'm just gently pressing anterior to posterior as I turn her head just a few degrees. We don't need to go through the full range of motion in order to feel kind of these vertebral tendencies. And so what I'm picking up on here is on her left side around C3-4. There's resistance to that left rotation. And as I come and feel that a little more, getting a sense of a little anterior inferior occiput on her left side. So that's like crowding her right here. And that's something we're going to want to open up for you, okay? Mm-hmm. So a couple deep breaths. I'm going to bring her neck back to neutral or even slight extension. And, you know, my instinct is to adjust this, but there's a lot of tension on that upper sternocleidomastoid that I don't want to adjust through, because one, that would be uncomfortable, unnecessary, and we don't want to strain the muscle. And, you know, just from a be gentle point of view, it's like, well, maybe if we release this sternocleidomastoid, the occiput and those two cervical vertebrae will just resolve themselves. That happens a lot. Which is why I don't adjust people as much as a lot of other chiropractors do, because I find that if we do the muscle work and get the muscles to release, a lot of times it makes the adjustment unnecessary. And if it is still necessary, it's certainly easier, more comfortable, more effective, and lasts longer. So that's what we were just doing, was giving her SCM a little bit of a stretch and trying to induce a posterior superior movement of her left occiput and anterior to posterior movement of those cervical vertebrae. It was kind of, if I was doing it on her right side, it would look like this. So I've got her mastoid right here, so I can induce that movement right at the occiput. Good. And so what I'm feeling is that the occiput did let go with those efforts on the SCM muscles. So let's adjust C3-4, okay? Okay. So I can bring C3-4 from A to P on the left by going lateral to medial on the spinous on this side. And it's easy. And good. And let's finish it this way. Give me a nice deep breath. Let your chin relax. Good. Gentle. Good. Good job. Okay. So now you're all fixed forever and you'll never have any problems again. Yeah. Keep doing what you're doing. I think you're doing great. And I just preach patience with your right leg.
Okay.
It may never be completely symptom-free, but you're not there yet.
Yeah.
It's been 1.5 years since surgery. So Feels like a long time, but when it comes to spinal surgery, I do think 2 to 3 years is a reasonable window. Okay?
Okay, thank you.
You're
so
welcome.
much.
Any questions?
No.
All good?
Yeah.
Thank you, Jeneen. It's good to see you.
You too.